I would like to go back and open up this time period now to general questions. And I wanted to shift back both to Igor and Wei Shu's presentation, where they were looking at the Medicare data going back, at least considering the Medicare and multiple cause of death data going backwards in time to the early 1990s. And what's very clear from those graphical presentations is that there's an increase, something on the order of a factor of 3 in the prevalence of dementia in that time period. And so I find it to be most compelling to consider that the real population did not have a jump of a factor of 3 in the prevalence of Alzheimer's, but that there is a component that could be described as an artifact of the adoption of dementia coding practices within the physician and other care medical provider population, such that over time the dementia codes and the Alzheimer's codes were added and became increasingly more prevalent in the Medicare data, peaking sometime in the mid-2000s. And so I would like Igor Kusevich and Wei Shu to each just briefly comment on whether they would agree with that assessment, and if so, how that would impact our interpretation of their analysis, and more generally, the use of the same data by other attendees within this Zoom conference setting. So Igor, I guess, can go first.
Thank you, Eric. Thank you. I would emphasize the importance of Medicare data for our analysis, and we see that almost everybody from our presenters used Medicare for their analysis. Concerning frailty, so we we used also frailty estimates and respective time trend. Dr. Kim demonstrated his associations between frailty and dementia. Dr. Kim, can I ask a question about time trend? Whether did you measure time trends using Medicare data, or you just use your 14 and 16 year data set?
Well, thank you for the question. So in that analysis that I showed, I did not consider time trend necessarily, because we only had fewer than 3 years of follow-up during that period. But with my based on my experience using frailty index, applying frailty index over a much longer time period, sometimes the coding practice and certain diagnosis and services code may appear more often in certain years and may retire in some years. So that definitely affects the performance of a claim-based algorithm. So it seems necessary to check, the performance of the algorithm periodically, especially when there is a major shift in the coding practice or coding system.
Can you make a conclusion about racial or geographic disparities on your estimates? So do you have different patterns for different racial subpopulations?
Yeah, when we look at the variation, geographic variation, also the racial variation using the race information in the Medicare, we also found that there is a significant variation in the total Medicare cost among the patients with or without dementia and frailty, those four mutually exclusive subgroups. So we are in the process of investigating where that disparity are really coming from in more further detailed analysis right now.
Okay, so let me ask Viju to respond, and then I would come back to ask my further questions.
All right, thank you for the question. I completely agree with all of the above assessment that the changes in Alzheimer's disease and dementia coding, diagnosis, and reporting practices are complicating factors for our results of the future projections of ADRD prevalence, and also the geographic disparities in dementia mortality. Not only the temporal changes is a complicating factor, the geographic variations in the dementia diagnosis and reporting practices at one single point of time can also be a complicating factor, especially when we are trying to look at the geographic differences in mortality risk or medical care costs associated with dementias. So a simple let's look at it is the division between urban and rural areas. So in rural areas, most likely those places will lack the necessary medical resources or personnel for accurate dementia diagnosis. So there is a potential problem that dementia cases are under-diagnosed or under-reported in those areas.
Okay,
So,
good, thanks.
Thank you.
Igor, I was going to just add in, I had two further questions. I had one for Dr. Brookmeyer and then a follow-up for Konstantin. Both are related, so I'll ask them just as I'll pose them as one question. And this comes back again to the temporal trends. What's a real trend and what's not a real trend, diagnostic or a coding practice change. There have been numerous reports in the literature about declines in both incidence and prevalence of Alzheimer's disease or Alzheimer's disease plus other dementias. So my question for Dr. Brookmeyer is, when you are setting up a Markov model, it seems the basic or the starting assumption would be that all the different covariates you're putting in account for these trends. And so you don't have explicit, unexplained temporal trends built into the model. And I just wanted to confirm if that in fact was the approach that you were using, and if so, what would be the implications of those trends, those unaccounted trends not being modeled. And then secondarily for Konstantin was whether the stochastic process model approach that he presented would resolve the issue, any of the issues that you say or would indicate would not be resolved by the simpler Markov approach.
Great. Well, thank you for that. I mean, that's a great question. I mean, the big question is, what is the, underlying transition rates? Will there be secular trends? We used recently published transition rates of the biomarker states. So those are current, are based on basic current cohorts. And where we're looking at transitions over the last few years. And those were the ones that were used for making estimates now and into the future. So we weren't using historical, older cohorts, because we actually didn't even have biomarkers then. The biomarkers that we have have been recently developed and used. So the transition rates are, in a sense, contemporaneous with where we are now. Having said that, and those were used to then make forecasts into the future. But having said that, while I think I have confidence in those projections, but going in the near term, but going into the long term, whether or not transition rates change in 2060, that is, that is an inherent uncertainty. And clearly, that's what, when we looked at the scenarios of what different interventions could do into the future, that's exactly what we were trying to get at. Suppose those transition rates changed from what we estimated, what could we see happen?
Okay, and so thank you for that answer. And Konstantin, if you want to jump in and add any comments about whether the stochastic process model, which I'm viewing as an alternative to the Markov model, would in any way allow us to address the same issues, which is essentially unanalyzed or non-identified temporal trends.
Yes, that's actually a very big question, and I can tell we are just in the very beginning of our pathway to construct the let's say multi-state stochastic process model. So I think the key component in answering to this question is what data we have in hands. Because we can imagine the most sophisticated model in the world, but when it comes to estimating something, you have to have something in hands, some real data, unless you know how to circumvent it and, let's say, integrate out something out of your model. And I think it's also important point here, because as I mentioned during my talk, we thought about applying our model to 5% Medicare data, in which case we actually have less information about relevant variables than we have in HRS, for example, but we have much larger sample size in this case, and we can do refined analysis, and we can maybe estimate trends if you wish more reliably in case of 5% Medicare data rather than what we are able to do in case of HRS data, even though the time frame, the available time frame is more or less similar in both those data sets. Still, the sample size is much higher. That's why it's more reliable in this case. But again, coming back to this point that we don't have other covariates, it necessitates developing the approach how to integrate out some dimensions, I would say, some variables out of the model if we don't have it in the data. Fortunately, we have such formalism, and we have a paper published, if I'm not mistaken, in 2011 in Mathematical Bioscience, or Mathematical Population Science, I forgot actually. And that is a kind of a background behind this, and it could be further developed in this direction, and I don't see what can stop us.
Okay, so I think if I'm understanding the two answers I've heard, this question is a complex question, and it's going to involve data availability, modeling, model capacity, and there is yet much work to be done to get an answer to that. Okay, so Igor, you had a question that
I had a question. So to Dr. Brookmeyer. So it's clear. So the core of your modeling are transition rates. It's clear that they're heterogeneous. So, and we can't estimate, so the rates could be different for different population groups, right? And we can't estimate everything. The question is what we can estimate from data now and what we can't. And can Medicare data help you somehow to improve your estimates?
Well, I don't know if I can answer about the Medicare data and what it can do. What I can say is we have a lot more work to do on understanding the role of biomarkers. We have a lot more work to do in understanding how we define, I think, mild cognitive impairment that are culturally sensitive, that are appropriate for diverse populations. So I think that there's more to do. I think when I look at next steps, I'm looking at tau in terms of a biomarker. I'm looking at is enough data accumulating in cohorts longitudinally to measure the transition rates as we fine-tune our biomarkers? Are the cut points that are used for when you say someone has preclinical disease, the thresholds for amyloidosis and tau and so forth, how reliable are those? So I think there are a lot of questions, and I think it involves more work on biomarkers, more work in diverse populations that are culturally sensitive to really reduce a lot of the uncertainty that we see.
Dr. Brookmeyer, actually we have two additional questions from audience to you. One of them about transition measured across 13 countries. So languages are different, assessment and clinical definition are different, maybe not standardized. What would you comment here?
Yeah, well, first of all, I would say doing work across countries is really important. We want to see consistency. And what we often see is that there's a lot of heterogeneity across countries, although the big trend of the doubling every 5 years where you see the threshold and you cross Alzheimer's may vary depending upon the criteria that are actually being used. That doubling of 5 years we see consistent, which is a key message. I think in terms of the different criteria for mild cognitive impairment, whether it's developed on the international working groups or the NIA-AA criteria, it's important to be looking at different criteria. And I think in using Z-scores is one way to help standardize. But I certainly agree that attention being paid to international differences is really important for us all to be doing.
Mm-hmm. And another question is about the last figure you demonstrated, where you demonstrated lifetime risk on Alzheimer's disease for men only. And the question was about women lifetime risk. Do you have this information?
Of course, absolutely. And I only showed the men because I was running out of time. But it is in table 1 in our lifetime risk paper is the one for females. But I just want to say something about the gender difference. The lifetime risk for females is going to be greater than for males. And so, for example, and that's because women live longer. So that, for example, a 75-year-old normal female, her lifetime risk that we estimated was 14%, whereas for males it was 11%. For a 75-year-old female who has amyloid in the brain, her lifetime risk was 24%, but for males, a similar male, the risk was only 17%. So that difference is coming about because of the different death rates. And the lower the death rates, the higher the lifetime risk is of developing Alzheimer's.
Thank you. Thank you for your responses.
Okay, I'll jump in. There was one more, if we have time. Igor, you can make the call on this. This is for Dr. Shu. And the question is, can you, this refers to table 2 on your slide, which is also table 2 in your paper. Can you explain more what the table 2 on your slide means when you, and this is the last column, when you refer to percent of study population as a share of US population? In the last column, there was a question what that means. I think, let me just offer my guess as to what that means, having quickly looked at it, is you're restricted to the fee-for-service population in your analysis. And I think you've taken the ratio of that subset of the Medicare data to the total population. But why don't you go ahead and confirm or comment however you want on that?
Yes, for sure. So the table 2 shows the number of fee-for-service beneficiaries and the number of fee-for-service beneficiaries diagnosed with ADRD in 2014 by different demographic characteristics. The last 2 columns show the share of the study population as in the US population by different groups. So in terms of race and ethnicity, we can see the non-Hispanic white population was much better represented in the Medicare fee-for-service population. It points to a need to increase the racial and ethnic minority populations in the Medicare programs.
Thank you. Eric, if before we finish our discussion today, we need to announce pools. We are ready to launch the first pool in our workshop, and Galina can provide some details about that.
Yes, this is Galina, and I would like to thank everyone who joined us today. And right now I'm going to launch the first question. I hope you will participate and will help us to get prepared better for the next time. Thank you.
Thank you who responded. I see a lot of responses. Thank you very much. So, Eric, do we have anything else for this discussion?
I think all the questions that were posted on the online question were done, and all the questions I had were done.
Okay.
So the only question would be whether any of the presenters had questions for other presenters. Otherwise, we're scheduled to restart again at 1:30 p.m. with the afternoon session and the afternoon chair in control. So
Thank you. Thank you very much, Eric.
Good, thanks.
Thank you.